Today, I'm really happy to introduce Dr. Kayoko Shioda, who actually began her training as a veterinarian, and she completed her DBM at the University of Tokyo in Japan. She then, fortunately for us, came to Emory to complete her MPH in epidemiology in 2014, and then went on to do her PhD in epidemiology of microbial disease at Yale in 2020. And then she came back to Emory as a postdoc, where she worked with Ben Lopman and others. And then last year accepted a faculty position at Boston University, where she's now assistant professor. Kayoko's research crosses many scales by bringing together global health, One Health, vaccine epidemiology, and patient statistics. She's interested in identifying climate-resilient measures to control zoonotic pathogens, as well as in informing vaccine policy, particularly for resource-limited settings. In addition to all of this, she's a brilliant teacher and mentor, and I've been very lucky to work with her a little bit. So thank you for being here today, and we look forward to your talk.
Thank you so much. Thank you so much for this opportunity. Getting invited to talk at Emory feels so special to me because I graduated from the MPH program here at Emory. I was MPH student from 2012 to 2014, and I just learned so much when I was an MPH student. It really opened up so many doors for me, and I'm forever grateful for the training I got at Emory. So it just feels so amazing to be back here and talking about my own research. It just feels so special. So thank you so much. And today's talk will focus on the transmission dynamic modeling, which is the tool that I use for various different research topics. And the talk will be divided into two parts. The first part will talk about how human behaviors are incorporated into the transmission dynamic modeling. And the second part is how we can use transmission modeling for One Health research. As Maria said, my background is veterinary medicine, so I also work on One Health research. Okay, so let me go to the next slide. Oh, please. Okay. I want to introduce myself because, as I said, I graduated from Emory, and when I was a student, I always found it helpful to know what alumni are doing after graduation and so on. Maria already gave the really great introduction, but I will just briefly add a little more information so that you can see what you can do using the knowledge and skills that you get from Emory after graduation. So I'm originally from Japan, and my family moved to South Africa in my childhood because of my father's business, and this is such a special part of my life. This is exactly where I got interested in One Health. Of course, back then I was like 10 to 12 years old, so I didn't know the word One Health or public health even. But as you can probably imagine, lots of different things. And there are lots of different things between Japan and South Africa, like cultural norm and value and language, the communication, of course, healthcare system and infrastructure. There are so many different things, and that triggered my interest in human health and animal health and environment. And here I am. So this is a very important part of my life. And after coming back to Japan, I decided to be a veterinarian because I was interested in One Health. And then I moved to the US to do my MPH in epidemiology. That was from 2012 to 2014. I'm sure you know Christine Nelson. She was my MPH classmate, and so I've known her since 2012. And I worked at CDC as an all rights fellow after graduating from the MPH program. And then I did my PhD in epidemiology of infectious diseases at Yale. And then I was also working at the WHO as a staff consultant. And then I came back to Emory as a postdoc, and I was working with Ben Lopman in EPI and Dr. Matt Freeman in EH. I was hired by 2 different research groups, which was a really amazing experience. And I was working on very different projects, but learning a lot in both of these different departments and different research groups. So that was a fantastic opportunity for me. And then now I am working as an assistant professor at Boston University. I am in the Department of Global Health. I also work as a research core director at the Center on Emerging Infectious Diseases SEED at BU. I'm going to talk a little bit about that in the end of the presentation. But that's my career path, and so far I have been fortunate to work in or with more than 30 countries for my research project, and I'm excited to share a few of them today during this talk. So, okay, I don't know if there's a way to, I just have to click OK here, I guess, right? Okay. So my research interest is infectious disease epidemiology, and the overall goal is to identify effective control measures based on the understanding of transmission dynamics and the impact of interventions. And I work on two different areas. One is vaccine epidemiology and intervention evaluation, so how well vaccines are working, how many lives have been saved because of vaccine. And the other thing is One Health with climate change. But for both of these fields, I try to develop or adapt advanced epidemiological methods so that we can generate reliable scientific evidence that can inform policy globally. So that's the whole picture of my research activity. And the first part will focus on the vaccine epi work that I have been doing. And this specific project is focusing on understanding how people change social contact patterns when they are sick. And this is actually the first time I'm giving a talk about this project, so I would really welcome your feedback on this. But I'm just taking a step back a little bit and try to give a background of this. How many of you have used mathematical mechanistic model for your research or took a course? Yes, so many of them, yay! We don't have to talk about it, I guess, but the basic SIR model is written there. But for those who don't know, maybe I should talk about that a little more. But basically, this kind of model, can track how many people are susceptible for infection, how many people are infected and infectious, being able to transmit pathogens to other people, and how many people are recovered that are. So these are people in our compartment, they are immune, so they don't get infected. And you can simulate outbreak or endemic situation using this kind of model. And using this, you can understand the epidemiological characteristics of the pathogen or the circulation of the pathogen, or you can evaluate the impact of control measures like vaccines and isolation. How many people did not become sick because of vaccines or because of isolation measures and so on. And this kind of model can be used to forecast the trajectory of cases, infections, or death, hospitalizations. And these results can inform health policy, hopefully in a useful way. So that's the mechanistic modeling. And then when we think about the rate of moving from one compartment to the other, especially from the susceptible compartment to the infectious compartment, S to I, the important thing is that the force of infection, which depends on various factors. The first thing is how many people in the population are infectious, right? If there are more people who are infectious in the population, of course, the disease spreads faster. And the other thing is how often people come into contact, right? This is exactly why it is important to understand the social contact pattern in the population, and then the transmissibility per contact. How likely do you transmit pathogen to other people per contact? So because of this compartment here, a component here, how often people come into contacts, the rate of contacts, that's the very important part of the force of infection. So that's why we are trying to understand the social contact pattern, especially among sick people. And when we talk about the social contact patterns, very famous study. It's called PODIMOD, which was conducted in 8 European countries in 2005 to 2006. And in this study, huge multi-country study, more than 7,000 participants recorded characteristics of approximately 98,000 contacts during the 24-hour period. And they reported their age and sex and location, duration, the frequency, and occurrence of these contacts. So if you work on a social contact pattern, this is a very famous figure that you always look at. But here, the x-axis and y-axis, these are the age. So which has a range from 0 up to 80. And then x-axis here is the age of participants, so the people who answered the survey, and this is the age of contacts, right? And then it's like a heat map. So there are lots of contacts happening here on this diagonal, which is understandable. So it means that people are having more contacts with the people in the similar age group. Because here we are in school, university, taking classes, seminar, participating in a seminar together with a similar age group people. And the other part, the Great Britain is easy one to understand. I think it has a really clear line here. This is representing the parents and the babies and the kids. So once people become around like 35 or so, they start having babies, and then it increases linearly, which is representing the aging of the parents and their kids. And then Dr. Prem and other people did a really wonderful study projecting social contact matrices in more than 150 countries based on the contact survey data and also demographic data. And so now, because of this paper in computational biology in 2017, we have some sort of extrapolated or projected contact matrices in 152 countries. And this is for Germany and Bolivia and South Africa as an example. So now that we have these good data, I guess, that you can incorporate into the transmission modeling, some of the mathematical models started incorporating human behaviors based on these empirical data, especially after the 2009 influenza pandemic. So what are the challenges at this point? So there are challenges with the data and also the model. So let's first think about the data issue with the data. The first thing is that contact data have usually been collected from healthy people or without knowing the respondent's health status. So we don't know if they are sick, or usually the people who responded to the surveys, they are healthy people. So we don't know how sick people change their social contact patterns over time and so on. But when we think about the social contact patterns among sick people, contact tracing is actually one way to collect that, right? But the challenge with contact tracing is that we first identify the cases, and then we talk to them and ask about who did you contact yesterday, 2 days ago, 3 days ago, and so on. So there is always this recall bias. So it's not the real-time prospective data collection, right? It's always retrospective. And then when we think about the exposed individuals, for example, like parents taking care of sick kids, or maybe healthcare providers taking care of the sick people, we don't really have any data on these exposed individuals, the close contacts of cases, and how their social contact patterns change over time. That kind of data are altogether lacking. But when we think about the transmission, the behavior of sick people or the behavior of asymptomatic cases are the most important part, right? Because they are the ones who transmit the disease to other people. So the lack of data in this population is a huge challenge. And then when we think about the model, models usually have to make a very extreme assumption. One of them is that we assume that contact does not change over the course of the illness. So even if people are sick, we just assume that they don't change the contact patterns, because it's actually helpful to include all of these heterogeneity of contact patterns in mathematical modeling. It's really complicated. So let's assume that there's no change. But then the issue would be, if we do that, the true contacts during the infectious period, this contact rate here in the equation will be overestimated when we fit the model to the data to estimate these things, which means the transmissibility per contact, this parameter here, will be underestimated if the true contacts during infectious period is overestimated. The other side of the extreme assumption is that when people are sick, their contact reduced to the perfect isolation. So when they're sick, they just stop contacting anybody else, which means that the true contact rate during the infectious period will be actually underestimated when fitting the model to the data, which means that transmissibility per contact will be overestimated. And when we estimate the impact of vaccines or the impact of isolation measures, their estimates will be dependent on these things. So if there's a bias in these things, your estimated impact of interventions will be also biased. So these are the challenges with the models and data. So in order to tackle these things, we decided to do this study in which our research question is, how do people with acute respiratory infection or gastroenteritis change their social contact over the course of their illness? And what about their household members, these close contacts, exposed individuals? And this is the collaboration with Ben and Sam at Emory, and also our very important collaborator is Kaiser Permanente Northwest, which is doing the case identification and recruitment and data collection. And SICK-MIX, the name of the study, is actually named by Maria. You came up with this name. And then it's really perfect because Ben and Sad Omar at University of Texas, they have series of social contact studies, actually, global mix, which is what Billy has been working on, I guess, right? And then corporate mix and so on. So we wanted to use mix, and we were trying to come up with a nice name, and Maria did, and we used the chat GPT to reverse engineer with sort of work, I guess. We love this name. But our hypothesis is the behavior change does occur when people are sick with the acute infectious diseases, but not to the level of perfect isolation. And we want to understand that level. And these changes do have a substantial impact on in-part disease dynamics and estimated impact of interventions and so on. So that's our hypothesis for this project. And actually, there are two previous studies that collected social contact data from sick people. One is from Malawi in 2017, and the other is from UK. I thought I would show a little bit of these studies to share more information in this field. But in this Malawi study, this is the main figure from the paper, but this one is showing the mean average number of contacts per 24 hours on the day when sick people visited the clinic. And then the second row is the next day, the day after the day when they visited the clinic, and then 2 weeks later. And this is for the patient under 5. This is for patients from age 6 to 17, 18 plus, and these are the caregivers. So if you just look at the length of these bars, you notice that the number of contacts didn't really change between the time when they were sick and when they recovered, right? This is about like 17.5-ish for the clinic today, and it only reduced to like 15. Actually, they have more contacts on the day they visited the clinic, which is probably understandable because they went to the hospital and so on. Let's see. Yeah, right. So it may seem that there were no big difference in number of contacts when ill versus well, but that was because of this. So this second graph is showing the number of contacts, actually the mean difference between the day when they were sick and when they were healthy. It's a little bit difficult to digest, but basically the dots on this side of the bar means that there are more contacts after recovery, and this side is more contacts when they are sick. And again, these are stratified by age group, and this is the household, within a household. Well, actually, no, this is the contact with household members, and this is the contact with non-household members at home, non-household members elsewhere. And the reason why we didn't see much difference in the average number of contacts was because when they were ill, the contacts with non-household members at home increased, while contacts with non-household members elsewhere decreased. So when they are sick, they were not contacted with the non-household members elsewhere, but they were contacted with more non-household members at home, because in Malawi, the community people will come to your house to take care of you when you're sick, which is so sweet, and I think that's really wonderful. Not happening in the US, I think. But because of that, you see no difference when you are just looking at the average of number of contacts, right? So this gives us an idea that it's important to understand the setting of these contacts. And the other study was from the UK, and about 300 people completed the first questionnaire, and 174 completed the second follow-up questionnaire. But the result was the average number of contacts when they are sick and healthy. You see a lot of difference here, right? That's like 15 and 4. So in the UK, there is a very big difference in the average number of contacts. So this is showing it is important to understand the trend in different countries with different culture. And this is showing the again, a little bit busy figure, but these blue dots show the average number of contacts when they were healthy on left, sick on right. So it's easy to understand actually. When they're healthy, they have lots of contacts at the work, and then when they're sick, of course, the number of contacts decreases. But then at home, the number of contacts actually don't really change between the day when you are sick and when you're healthy. So these two studies were the motivation to conduct this NSF study, our study, to understand the trend in the US, which there were no studies evaluating this before, and also after the pandemic, because many perspectives about like isolation and social distancing changed obviously before and after the pandemic. So we decided to do this study, and so in this 6-week study, we are recruiting 500 acute gastroenteritis cases and 500 acute respiratory cases. And we're also recruiting their household members, which are the close contacts or exposed individuals. And then we're doing the online social contact survey. And in these surveys, we are asking how many household members did you have contact with, and then their age and the duration of the contacts. We also ask how many non-household members did you have contact at your home or work or school or other general community. And we also ask about the age group and duration of these contacts. And then the time frame of this study is that, as I said, we are collaborating with the Kaiser Permanente Northwest. So when these sick people seek healthcare at Kaiser, we can detect that by pulling the list of ICD-10 codes every day. And there are specific ICD-10 codes for AGE and ARI. So once they are identified in the database, the invitation email will be automatically sent to these identified cases. And then we, after answering the consent and enrollment survey, they will answer the first social contact survey, which will be about contact on the day when they felt most sick. So we asked, when did you feel most sick? Was it 1 day before, 2 days, 3 days, after 6 days? If they say I was sick, most sick, 8 days before today, then we will actually exclude them to avoid any recall bias. It could be after 6, but then if it's more than 6, we exclude them to control the recall bias. But the first contact survey will be about the day when they felt most sick. We also do 1 week follow-up and then the 2-week follow-up to understand how people change the number of contacts at different places over time. We also ask about the health status in each of these surveys. And we also ask if they changed any behavior. Did you wear a mask because you knew you were infectious, or did you have less contacts, or did you try to reduce the duration of the contacts? Did you try to put some distance between people? Did you try to have contacts outside instead of inside? We ask all of these questions. And then we also recruit household members, and we do the survey on the same day. So this survey, the first survey for household members, is asking about their contacts on the day when their sick household member was feeling most sick. And then it was 1 week later. And we're not doing 2-week follow-up for household members because we don't think they would change behavior that long based on the fact that their household member was sick. So that's the timeline. And then eventually what we're aiming to do is to incorporate such empirical data on temporal changes in social contact patterns into a transmission dynamic modeling. This is just an example, but here, this one is, we are calling behavior naive model. So it's assuming that there is no temporal changes in social contact pattern during the infectious period, it's constant. So that's why there's only one compartment for symptomatic period or asymptomatic period. But if we see any changes in any temporal changes in social contact patterns among our cohort, then we would probably include multiple compartments for the acute phase of infection and the later phase of infection, and try to incorporate different social contact matrices into our transmission modeling. And we are modeling rotavirus and fitting the model to the market scan data. And for COVID, we're fitting it to the COVID surveillance data. So rotavirus is an example of AGE, and COVID is an example of ARI, which we are collecting data on. And yeah, lots of BU students have been helping with the project, and we actually just started the data collection like 2 weeks ago. We were originally planning to do it in October, but here we are in March. We just started. So unfortunately, I was hoping when I got invited to talk at the IDAS seminar a while ago, was it in the fall or something, right? Back then I was like, we're starting data collection in October, so I will have results to present at Emory in April, but unfortunately it was delayed a little bit, so I don't have any results to present yet. We started data collection 2 weeks ago, so some people have completed 2-week follow-up already, which is really exciting. We thought this design is a little bit complicated because people are supposed to answer 3 contact surveys. And depending on when they open the invitation email, it could be already like 1 week after when they were feeling most sick, and all of these timeline could be very complicated. So we're really excited to see that this data collection scheme has been working, at least for some people. Yes, so that's the first part of the talk, focusing on the human behavior, incorporating human behavior into the transmission dynamic modeling. I'm happy to answer questions for this part. Yes.
Yeah, that's super interesting. So I'm wondering in terms of comparing behavior-driven model, behavior-naive model, right? Even if you have the same contact matrices in the behavior-driven model compared to the behavior-naive one, you have different distribution for how long individuals remain infectious, right? Because you've got two compartments there, you've got one compartment there. So I'm wondering those two different models rather than the behavior-driven model for both of them, where you have the contact matrices just being different.
Right. What we are hoping to capture is the temporal changes, right? Like, so that you are right that the distribution of the duration of the or the distribution of is different. Yeah, will be different. This will be like exponential, while this will be maybe gamma. That's right, I actually didn't think about that. But what we are trying to capture here is the acute phase, they reduce the contact quite a bit. But then 1 week later, which people are still infectious, but then they feel better, so they start going out. Like CDC's guidance on isolation was 5 days. And we knew that some people are still infectious. So that's the part that we are trying to capture. But it's true that the distribution will be different.
That second model you have, and just keep the contacts the same between those two different eye compartments?
No, it'll be different. So these people in I1, acute phase of infection, they will have much fewer contacts. In I2, the later phase, they will have a little more contacts.
Right, so what I'm saying, can you just use that behavior-driven model structure, right? And put it into the behavior-naive model, only make the contact.
Sorry, got it.
One, yeah.
I am so sorry.
Just the control for the infectious distributions.
Thank you so much. I will take a note of that. It's recorded, so it's great. Thank you so much. That's great advice. Thank you. Yeah.
I have a much more naive question than that. I thought it was great. But so I'm just trying to think about the model itself. So you have infected or infectious and then asymptomatic. Is there, as you go straight from asymptomatic to resistant, is there any, is there never transitions from the asymptomatic to infectious or infected?
Right. So for example, for COVID, we have this pre-symptomatic period. Before being symptomatic, they're infectious but not having symptoms. So that could be included here, and then they could go to asymptomatic infection or symptomatic infection. Yes, yeah, that's an important thing to consider when we are actually building model. Thanks. Yeah,
I have some public health related questions.
Yes.
So I'm wondering, like, cases know they should be social distancing or practicing some precautions. So how do you account for that bias? Because that's going to kind of exacerbate your infection metric, right?
Yeah, so as I said, the survey asks whether you reduce the number of contacts or putting more distance between people. And because of the pandemic, the messages that we send during the pandemic, people know that's what they're supposed to do. So what we try to do in the survey is there's no correct answer. We clearly said that, and then we just need to know what you really did. We're not judging you. It's anonymous. So we try to make the survey sound less judgmental. And when we had the list of these preventive measures, the first choice actually says, I didn't change anything. So that we can give the impression that it's okay if you didn't change anything. So instead of putting that option all the way at the end of the long list of these things, mask wearing and hand washing, we put that up front to give the impression that it's okay if you didn't change it. You can pick this box and move on.
Another question.
Yeah.
So you said that you were hoping this model would be generalizable for the US, maybe. But I'm also wondering about that because we all know that like certain communities are like aggressively anti-mask, et cetera. So I'm wondering, like, do you capture some data on people's pre-existing beliefs about the importance of these sorts of precautions or their pre-existing beliefs on masking or things like that?
Right, like we don't get any of these things, but I mean, of course, we get the age and race and gender.
This is all happening in one part of the US or what? Sorry.
Right, sorry, this is the study is with Kaiser Permanente in Northwest, which is located in Portland, Oregon. Their catchment area is like southern Washington and northern Oregon. But the good news is that Ben and Kristen and everyone at Emory will be doing almost similar thing within Georgia with the Kaiser Permanente in Georgia. So we will have at least two very different communities contributing to this study. And it's true, the age and race and these things are not enough to categorize social contact patterns. This is what we have been doing. So there has been a lot of debate, which is interesting. Like marketing people never use data on like age and sex and race anymore. Apparently, they rather use Swifty or which kind of music do you listen to? That has more implication on predicting which products they buy, each person buys. So like, we are so focusing on age, race, and sex, and then like, these basic demographic factors. It's these marketing people never use so yeah.
Yeah, I think with you mentioned the pre-symptomatic, which I think is going to be really important when you're talking about COVID versus acute gastroenteritis, because one of the insidious things about COVID is you were infectious before you felt sick. So you change your behavior after you've already done the damage.
Yeah.
So in some sense, comparing those two outcomes on the model and what that does, because maybe you change your social contact after you're sick, but you've gone to school for 2 days or 3 days, 4 days, and you've already kept the infection going. And that's the sort of thing, like every time there was a new strain, the first report would be the middle of Kansas. You're like, well, if it got there, it had to have gotten through a lot of places. So if the behavior change in the infectious period don't happen in the right order, then your model, I think, could show that. But I think you have to think of COVID really differently than some of these ones where I'm infectious with symptoms right away.
That's right.
So I think it will be an interesting outcome, but I think that pre-symptomatic component is going to be pretty important for the COVID surveillance.
Thank you so much. Yeah. Yes,
just to like clarify the survey structure, just so I understand, like you have your first survey, also got the index data and they felt the worst. Is it collecting any data from like before then, like what their normal behavior might be?
Or not. Hopefully the normal behavior will be captured in the 2-week follow-up survey. That's a hope. Because instead of asking information about a long time ago, it's always better to ask about the information today, right? So instead of asking weeks before, we tried to capture the normal behavior 2 weeks after identifying these cases.
So it's collecting data for like the index day until the first survey, or just the index day?
Just the index day.
And then just the 2 weeks later?
1 week later and 2 weeks later, but the 24-hour period of the 1 week.
So not asking about any of that time?
Exactly, no, it's just that day, so 3 days of data, yeah.
One other data set that's out there is Gonzalo's work on dengue. I mean, it's vector-borne, but they looked at household behavior, how many people come to your house when you have a fever. And, so it switched from being outside the household. Your family members stay around you, but now they're in the house with the mosquitoes and you. So they had some pretty detailed questionnaire data on that for Iquitos, Peru.
Oh, cool.
Which is another interesting spin on this.
Yeah, thank you so much for sharing. I will look into that. Thank you. Any questions or comments? Great. I will jump on to the next one, which is about the One Health research. And for the One Health research, I work on enteric infection. So the zoonotic pathogens can be transmitted directly from infected animals or through the contaminated water or food or the environment. And our research questions are, how many of these infections are coming from each of these pathways? We actually don't really have any empirical data to inform. Like 20% of Campylobacter infection is coming from water and 30% is from food. There is the WHO report that provides expert opinion on these things, but expert opinion is expert opinion. It's not really the empirical data. So that's what we are trying to answer, and also how that changes by weather and the season and climate. I think I'll skip some of the slides, but anyway, basically this slide is trying to say diarrhea is still a big issue. It's still causing like more than 1 million deaths globally in 2015. Okay, that's 10 years ago. So it's a very important leading cause of death. And the thing that we always overlook is the reinfection, repeated infections will contribute to undernutrition and stunting, which affects so many children even these days. And this undernutrition and stunting will lead to long-term cognitive deficits and poor academic performance, lower economic productivity in adulthood. And WHO has this goal to reduce stunting in children by 2025 by 40%. So it's a very important global goal that we are hoping to achieve. And as you can see, this has a disproportionate impact in African countries and Southeast Asian countries. So for the One Health research, as I said, I work on diarrhea. And this is the study that was led by Matt Freeman in EH. But when we think about the animal feces, they carry a lot of pathogens that can cause diarrheal disease in kids. And it turned out among these pathogens that cause diarrheal illness, the 28.3% can be carried in animal feces. So it's important to control transmission from animal feces. And just a quick quiz, when we compare the amount of animal feces and human feces, can you imagine which one has more amount, greater amount, and how big it is compared to the other one? It's actually, there's 4 times more animal feces than human feces globally. So appropriately controlling animal feces is really important. When we think about the WASH research, we tend to think about the human waste, but then animal feces are also really important part that we have to focus on. And animal feces is increasing globally because the poultry is the fastest growing sector. And domestic animals generate 85% of the world people waste. That's a lot. And then the global livestock population has been rapidly expanding, and poultry is the fastest growing subsector, which is estimated to grow 250% in 30 years in LMICs. And then I was doing postdoc with Matt Freeman, and our studies have been focusing on chickens because they carry important foodborne pathogens like Campylobacter and Salmonella. And these are the photos taken by Freddie and Karen Levy. But chickens are promoted as the very important development strategy in many of the low and middle income countries. So they are the major source of animal protein, nutrition, and income. So it's important they have access to chickens. But at the same time, they also carry important pathogens. So we want to balance the benefit and risks. And when we try to control these zoonotic pathogens, it's really difficult, partially because they can be transmitted through various different pathways. It's not just person to person, but through lots of different things: contaminated water, or environment, or the food, which is what we are focusing on. So again, we already talked about it, but the chickens are even contributing to empowering the youth and women, especially in the resource-limited parts of LMICs. So we want to ensure the food safety while people can benefit from poultry farming. So Matt and Karen's team have been working in Mozambique for many years, and this specific study is named Cheap, and I'm sure you have heard of it many times from Freddie, who was a PhD student, wonderful PhD student with Matt, and she's now working at CDC, doing great work. But we did this study in Maputo is the capital city of Mozambique, because 70% of chicken production is informal with without any regulations and without access to good biosafety measures and infrastructure. So it's really important to understand how this informal chicken production works in Maputo and Mozambique. And 90% of households purchase food from the informal sector. And children are infected with enteropathogens carried by chicken. So these were why we wanted to do this study in Mozambique. So we tried to answer what are the locations and behaviors that expose children to chickens, and where along the chicken value chain are key poultry-associated pathogens found, and what are the risks of childhood exposure, and what are the potential strategies to mitigate the risk. And so this part of the study is not what I led, but hopefully by talking about these things, I'm trying to give an example of what modelers can do in a huge group of people, including field work specialists and microbiologists, and all of these people with different skill sets. So this is hopefully provide an example of what transmission modeling can do within that huge study. But in this part of the study, we tried to map the chicken value chain. So this is the work that led by Freddie. But as I said, most part of the chicken production in Mozambique is informal. So without any regulations, we didn't really know how the eggs are transported from where to where, and chicks are transported from here to there. We had no idea. So Freddie and others went to Mozambique and interviewed stakeholders. And there are lots of different types of chickens in Mozambique, but here I will focus on broiler chickens. But basically what we found was that the message is basically, it's really complicated. So the eggs will be transported from breeder farms to commercial hatcheries, and the chicks will move to the depots, and then small scale farms, the grocery stores, or informal wet markets, or corner stores. These are the street stores. And then households purchase chicken products. And some chickens will be imported from Zimbabwe, Zambia, South Africa, Brazil, Portugal. And we also observe where children are exposed to chicken feces. And we saw children at small-scale farms, and live informal wet markets, and of course households. So there are lots of places, locations kids have chance to be exposed to chicken feces, which potentially carried important enteropathogens. And then we also tested carcass rinse samples and fecal samples. Again, this is led by Freddie. And what we found, it's really interesting. It's a little bit difficult to digest probably, but C stands for Campylobacter and S stands for Salmonella, and there was no contamination of Campylobacter or Salmonella at depots where the chicks are raised. But then when we moved to small scale farms, 61% of them had Campylobacter. When they moved to the informal wet market, 100% of them had Campylobacter, and you can see a little bit of Salmonella here. Basically, the message is that as the chickens progress along the value chain, the contamination level increased. And then here comes the modeling. So what's the most effective way to mitigate health risks from these enteropathogens? And in order to answer that kind of question involving different transmission pathways like water and food and so on, the transmission dynamic modeling could be very helpful. So this is what how the model looks like. And it made it a little more complicated than the previous version that we saw in the first half of the talk. But it's actually not too bad. The box at the top represents the people who are susceptible to infection. And the unique part of this model is that we have 6 different pathways represented by each of these orange boxes. This one is the person-to-person transmission. This one is the infection through water, contaminated water, soil, food, and direct contact with infected live chicken and all other sources. And another unique aspect is that these infected people can shed pathogens, salmonella or campylobacter, into the environment, soil or water, and the contamination level is being tracked by the parameter W or E, which is incorporated in the transmission rate over here. So the contamination level in the water W informs the transmission rate for this waterborne pathway. Same thing for soil here. E is included up here. So we can capture the kind of feedback loop involving environmental sources. And here is one of the main result figures, but this is showing what would happen when transmission through each of the specific pathways is reduced in the specific setting in Maputo. So this is showing how much the simulated prevalence of Campylobacter infection decreases after reducing each pathway. So each line represents the different transmission pathway. So this red line is foodborne pathway, and the green line is chicken, blue is water, and orange is person-person. And the x-axis here is showing the reduced transmission rate. So what happens if I reduce the foodborne pathway by 10%, 20%, or 50%, up to 100%, meaning eliminating the foodborne pathway completely? And this y-axis is showing the percentage reduction from the baseline prevalence, which is 8% for Campylobacter in Maputo and 21% in Salmonella, for Salmonella in Maputo. So how much reduction you can see by reducing each pathway. And there are too many data points here, but if we focus on these ones, these are showing how much the prevalence decreases after reducing each pathway by 50%. And the interpretation is, if we reduce the foodborne pathway by 50%, the total Campylobacter infection would decrease by 30. And then if you look at the other pathways, you can see that it barely decreases. So basically, the message is, it is important to control the foodborne pathway. And we did that for Campylobacter and Salmonella. And for both of these pathogens, it's very important to focus on the foodborne pathway. And we, at the workshop in Maputo, to share these results with the Ministry of Health, Ministry of Agriculture, Maputo Municipality, and Customers Association and universities to discuss what is feasible, what we can do to reduce Campylobacter infection, Salmonella infection in this community. Yes, so basically the food security efforts have been focusing on access with less attention to safety. So we have to make sure that there is that balance. And the WASH research has been focusing on the mitigation strategies at the household, but we also have to think about the upstream processes. If the meat and poultry products are already contaminated, it is really important to just ask household members to wash their hands and cook meat very well. So it's important to focus on the community level things as well. And then One Health strategies can hopefully ensure food safety while also making sure that the community can benefit from poultry products. And as I said, the One Health research needs collaboration. So at BU, I have been fortunate to be a research core director for the CID, the Center on Emerging Infectious Diseases. And we have 4 research cores, and I have been co-directing these 2 research cores. One is data science and surveillance, and the other is One Health and climate change and EIDs to facilitate the cross-campus collaboration within BU and actually with the external collaborators as well. And I guess I will stop there. I just wanted to say I am also fortunate to be part of the CDC InsightNet network. Emory is one of them, so I'm sure you are aware of this, but I am part of Epistone that's hidden behind the Zoom box there, but I am part of the consortium led by Northeastern University, which is named Epistone, and they're great people within Epistone, and Laura White and I are representing BU within the consortium, and we're excited to collaborate with the other consortium members as well, including Emory. But yeah, that's the end of my talk, and I'm happy to answer questions. I'm sorry, I have like 2 minutes left. But I can answer about the One Health part or anything about APIS-OV consortium or seed.
So I was just with the model where you had different pathways leading to the Campylobacter and the E. coli, or sorry, Salmonella. So it was the food, and so that, but that food that is chicken meat,
Yes.
right? Yeah.
Yeah.
Okay. So there was the live chickens that didn't have as big an impact as the actual food.
Right, yes, yeah. And we're hoping to collect the different food types in a next project. We'll see how it
But
goes.
that's really nice, right? When one comes out so strongly, because you have this really complex network,
Yes.
but it seems it can come down to just one thing, which should make it way easier to implement
Yeah,
control.
yeah, the food pathway has been sort of overlooked in a WASH research area, but hopefully we can include it more, but yeah.
Hi, Professor, thank you so much for this really interesting presentation. I wanted to ask, in addition to behavioral surveys for the first part of your presentation, have you also considered, or are you able to use like cell phone data? Also?
Oh yeah, cell phone data, yes. I mean, for this one, we are not using it, but yeah, as you probably know, there are a lot of studies using cell phone data or the Google data or Facebook data and so on. The important part of our study is to know the health status, and it's difficult to do that for cell phone data. And we also want to know the severity of the symptom and how that affects the change in social contact patterns over time, over the course of illness. So that's why we decided to collaborate with the healthcare provider like Kaiser. Yeah.
I'm not very familiar with the climate in Mozambique, but did you notice any seasonality to the data or differences in human behavior that could have contributed to the results?
Yeah, so that's actually the next step that we're hoping to do. That's coming, including the seasonality into. So we're hoping to collect the data over 2 years so that we can capture the seasonality in contamination level or even the human environment interface, meaning like in Mozambique, people change the source of drinking water between the wet season and dry season. So how does that affect the waterborne pathway? Yeah.
Thank you.